The meeting of the Health Professions Subcommittee will come to order now. Call the roll.
Senator Saslaw, Senator Newman, here. Senator Edwards, Senator Lewis, here. Senator Dunavant, here. Senator Suterline, Senator Pillion, Senator Barker.
Here.
Mr. Chair, we have a quorum.
All right. I got a note here to remind senators speaking that use the microphones in front of you because we are on live stream. And we do have a fair number of bills to take care of today. So we will do that. And start out with
Department of Technology.
Senator Kiggins.
The print issue of the New Yorker with the headline, Flying Aces. Artificial intelligence is transforming warplanes.
You come up here and it's warplanes we get, so.
What's going on? Let's see.
All right. Yeah, go ahead.
Mr. Chair and members of the committee, I have Senate Bill 414, which is a access to care bill for nurse practitioners. I have an amendment that I'd like to make sure everybody has a copy of. It's a simple amendment.
Okay.
What the bill does overall is that it just expands the number of non-physician providers, nurse practitioners specifically, that a supervising physician can supervise. So expands number from 6 to 10. The only, as far as I'm aware, the only other allied health profession that had an issue with this was the emergency room. They felt like they wanted that number to stay at 6. So that's what this amendment does, is it just keeps the emergency department number of nurse practitioners that a physician can supervise at 6. The rest expands to 10. And the reason behind this bill is because we were really looking for ways to help with the psych, behavioral health, mental health providers. We had many late night discussions. The only time of day I could talk to them was between about the hours of 9 and 10 p.m. because they are so busy. They are so overworked. They are just a workforce that we have asked so much from them and they have given. And so I wanted to help them. And how could we find a way to just allow them to practice, increase their access to care for their patients. So this was an ask from the behavioral health providers to the physicians felt like that they could do this. They could supervise more. 6 was kind of a limited number. I know as a nurse practitioner, we don't practice independently or autonomously unless we feel like we can. The physicians who supervise us are there if we need them. But this is absolutely something that, especially in the behavioral health community, that the supervising physicians felt like they could do. So it's a small ask, but on behalf of the behavioral health and other non-physician providers, I ask that Senate Bill 414 pass.
All right. Are there any questions of the patron?
I have a question.
Yeah, Senator Edwards.
I'm trying to understand. Line 50, there's a line 50, 10 nurse practitioners. Is this being changed to 6, or is this an add to it?
Increased to 10. So right now it's at 6, so it would increase the number of nurse practitioners to 10.
And then you have this insert. Is this a amendment?
The amendment just says that in the emergency department it will still say stay at 6.
Okay.
All right. Anyone want to make a motion to adopt the amendment?
So moved.
All right, we got a motion and a second. All in favor say aye.
Aye.
All opposed, no. All right, any further questions of the patron? All right, we'll take public testimony now. We're going to limit it to 3 minutes on both sides, 3 minutes on the those supporting it, and 3 minutes on those not supporting it. So anyone want to speak in favor of the bill?
Mr. Chairman, members of the committee, Amy Parent-Stavert on behalf of the Virginia College of Emergency Physicians, and we just wanted to say thank you to the senator for being willing to put the amendment on to remove the emergency departments. We just, our doctors thought that 10 was too much for the ER, and we wanted to keep it at 6, and so we appreciate that amendment, and that's all I wanted to say. So thank you.
All right. Anybody else want to speak in favor? Anyone in opposition? All right. We operate on motion.
Move we recommend reporting.
All right, there's a motion as amended. And I assume this does not have to go to finance, so we'll find out before the full committee. Okay. All right. So a motion has been made to recommend reporting of the bill with the amendment. I'll call the roll.
Senator Saslaw, Senator Newman, Senator Edwards,
Aye.
Senator Lewis,
Aye.
Senator Dunavant,
Aye.
Senator Suderline, Senator Pillion, Senator Barker.
Aye.
Ayes 6, no 0.
All right, thank you. Next up is Senator Marsden.
Thank you, Mr. Chairman, members of the committee. Senate Bill 542. This bill transfers responsibility for the written certification form that comes from a physician to the Board of Pharmacy from the Office of the Executive Secretary of the Supreme Court, and this is for the use of medical cannabis. When this form was first required, possession of a valid certificate was an affirmative defense to an unlawful possession of marijuana charge, which put the Supreme Court in the game. But legislation passed in 2020 of the General Assembly session provided that the unlawful possession provisions did not apply to a person with a valid written certification, and the affirmative defense language was stricken. There was no longer any connection between the certification form, which is completed by a healthcare provider, and any court process. So this bill is a recommendation of the Committee on District Courts. Just clean up and get the form with the medical people instead of the legal people.
All right. Are there any questions of the patron?
Move report.
Well, first we got to see whether anybody who wishes to speak in favor of this. All right. Oh, somebody coming now. Okay. Yeah, come forward so you could speak on the microphone. So.
Good morning, Mr. Chair, members of the committee. J.M. Padini on behalf of the National Organization for the Reform of Marijuana Laws. Thank you, Senator Marsden, for this bill, and we support it.
All right. Take a seat and grab the microphone. So.
Good morning, Mr. Chairman, members of the subcommittee. Hunter Jamerson for Jushi, a medical processor operating in Manassas. Very comfortable with the provisions of this bill, have discussed its implications with the Board of Pharmacy, and think it will have no interruption and streamline the process for patient certifications. Appreciate Senator Marsden bringing the bill. Also wanted to alert the subcommittee this same provision identically is incorporated in a bill Dr. Donovan has on the docket this morning as well.
Okay.
Thank you.
All right, thank you. Next.
Good morning, Mr. Chairman, members of the committee. Alyssa Padden with the Office of the Executive Secretary. I apologize, I was out in the hall and couldn't hear the conversation. However, this bill is a recommendation of the Committee on District Courts, and I'm happy to answer any questions.
All right, any questions? All right, thank you.
Thank you.
Good morning, Mr. Chair, members of the committee. Randy Pearson on behalf of Columbia Care, the medical cannabis processor in the Hampton Roads region. We support the bill and thank the patrons for bringing it forward.
All right, thank you. All right, if there's no one speaking in favor, is there anyone who wishes to speak in opposition to the bill? All right. We operate by motion.
Move report.
Second.
All right, we have a motion to recommend reporting and a second. Call the roll.
Senator Saslaw, Senator Newman, Senator Edwards,
Aye.
Senator Lewis,
Aye.
Senator Donovan, Senator Suderline, Senator Pillion, Senator Barker.
Aye.
Ayes 6, no 0.
All right, thank you. Thank you.
Thank you, Mr. Chairman, members of the committee.
Senator Peake.
Sir, thank you, Mr. Chairman, and members of the committee. Senate Bill 169, pretty straightforward. We do have a couple of amendments, Mr. Chairman, that are being distributed. And, we've been trying to get the Nurses Association on board with this bill, so we have restricted it and restricted it and restricted it, and that's the purpose of the amendment. And still they won't come on board, but I kind of disappointed by that, but are you ready for me, Mr. Chairman?
Yes, I'm ready.
This
Go ahead,
bill, I'm
sir.
bringing it by request, and it is by request of my wife, who is, she is a hospice nurse, has been for 6-7 years. She's a registered nurse, has been for 30 years. And unfortunately, with the way things have been going, and she works for a private hospice company in the Lynchburg area, and unfortunately, the way things have been going the past couple of years, they've had a lot of deaths at assisted living facilities, older people, and some at home as well. Under the current statute, only registered nurses can declare someone dead. So what has happened, you'll have 2, 3 people dying a night, somebody will be in a private residence, and they cover up, and talking about my wife, up to a 60-mile radius, and then 60 miles the other way, somebody will be in a facility who will die. And they only have one RN who's on duty at a time. But they do have numerous LPNs, and a lot of the facilities have LPNs, but almost none of them have a registered nurse there, and certainly not at night. And it's just a terrible burden. And the nurses are saying, well, they're not trained, they don't know. Well, I can guarantee you that a licensed professional nurse who is at one of these facilities or who has been nursing for any amount of time, they know when somebody's dead. And they can tell at these facilities when somebody's dead. It's not that tricky. And we've added this language to put only hospice people and only when they have a DNR. And I can assure you that the licensed LPNs can tell when someone's dead. It is a bill that we need. There's a huge shortage of RNs, as everyone knows, and the facilities are horribly understaffed. So I'd ask that you pass the bill.
All right. Do you want to propose this amendment?
Well, somebody.
Yeah. All right. Motion is made to adopt the 4-line amendments. All in favor say aye.
Aye.
All opposed, no. All right.
I don't know if anybody's here.
And is there anybody to speak in favor of the bill? Is there anybody who wants to speak in opposition to the bill?
Mr. Chairman, just a question. Well, you wanted to speak? I think this is, I get the idea, and I understand, and I think it's actually very kind for the families. I've had my father-in-law die in my home. And so it can be a very long, drawn-out process to get somebody to pronounce death. So I'm very empathetic to that. I have a haunting memory of training in medical school. I think there are very precise guidelines that are required to document death. Am I mistaken? Does anybody remember? But if so, is there documentation? Yeah, first of all, I'm concerned about liability for the LPNs. I'll say that first, and I don't know, does the liability displace to their company, or do they now become liable? Because that may be a problem for them, number one. And number two, do you have like a checklist? Like you must listen to have an absence of heart tones for this amount of there's a checklist.
Yeah. It would, Mr. Chairman, I would say whatever the RN checklist would be, the LPN checklist would be the same, and whatever the doctor's checklist, the RN checklist would be the same, and then the LPN checklist would be the same.
Do we need to say that to protect for liability?
I'm happy to add in any language that we would need. So if we wanted to add in conjunction, well, I mean, it already says so it already says a registered nurse can do it. So we're just adding a licensed practical nurse. So whatever a registered nurse has to do, or a physician assistant has to do, the LPN would have to do the same thing.
Ordinary standards. Okay.
And I would add the nurses, and that is one that the Nurse Association, Mr. Lamar is going to talk about, that they're not trained to do, but in their school. But I believe if we put in there, and that's up to the company if they want LPNs to do it, and then they can educate them, or the assisted living facility on the procedures.
Staff, you want to weigh in on?
Sure, Mr. Chair. On lines 45 through 47, it indicates that they will have to follow procedural regulations from the Board of Medicine.
Okay, perfect.
All right, thank you. All right, anyone speaking in opposition to the bill? So.
Mr. Chairman, thank you.
Have a seat and
okay.
Pull the microphone. So.
Good morning, Mr. Chairman. Andrew Lamar, representing the Virginia Nurses Association, as Senator Peake and I discussed. Appreciate kind of the narrow focus and the issue that he's seeking to address. From the Nurses Association's perspective, it's just the LPNs are not educated and trained, and it's not within their scope to make these types of physical assessments. I know the department is here and can probably speak to that more so than I can, but just wanted to express that concern, just given that it's not something that they're educated and training to do in terms of those assessments. And so expanding that scope in this case today and perhaps next year, it's coming back to make it broader in other settings. But I appreciate what you're trying to do and just wanted to share those concerns. Thank you very much.
All right, thank you.
Mr. Chair, I would add, I think there are about 15 to 20 other states, and North Carolina definitely has this, and that's what we looked to when we first brought it up. So,
all right.
Senator Sasslaw has something to say about if only 15 or 20 other states do it. Don't we like to be 50th?
I told them, I said, just as long as they don't give this permission to my wife.
All right. Is there anyone else who wishes to speak in opposition? All right. The bill is before us.
Move to report. Recommend reporting as amended.
Second.
All right. The bill has been recommended for reporting, and there's been a second. Any further comments or questions? All right. Call the roll.
Senator Sasslaw, Senator Newman, Senator Edwards, Senator Lewis, Senator Dunavant, Senator Suderline, Senator Pillion, Senator Barker.
Aye.
Ayes 8, noes 0.
thank you very much. It's good to see the lobbyists don't always win.
All right. Senator Hashmi.
Morning.
Good morning.
Good morning, members of the committee. My bill is SB 670, and it is identical to SB 456 from Senator Mamie Locke. And I would ask the committee that we roll my bill into Senator Locke's bill.
All right. All right. There's a motion to roll Senator Hashmi's bill into Senator Locke's bill. There's no further discussion. Call the roll on that. So.
Senator Sasslaw, Senator Newman, Senator Edwards, Senator Lewis, Senator Dunavant, Senator Suderline, Senator Pillion, Senator Barker.
Aye.
Ayes 8, noes 0.
All right. So Senator Hashmi's bill is rolled into Senator Locke's 456.
Thank you.
Is she going to present 456?
I will be presenting on her behalf today.
Okay.
And there is 2 amendments, and I believe we've got those. So I would ask that we accept these amendments.
Yes, anyone want to make a motion regarding these 2 amendments? They appear to be the same wording, just 2 different places in the bill.
Amendments.
All right, is there a second? All right, we have a motion and a second to adopt the amendments. All in favor say aye. All opposed, no.
What's going on, Mr. Chairman?
Yes.
Question I want to ask the Senator, what's going on? Is this for every doctor licensed in Virginia?
This is to address maternal mortality, and so it would primarily be for individuals that are working with in the OBGYN profession, but it would also be for all healthcare professionals, basically.
Well, what's going on that this is needed? I guess that's...
That would be part of my bill presentation.
All right. Okay, go ahead.
The substitute's been accepted.
Did we vote on that? No.
The amendments we voted on.
Yeah, that's what I thought. Yeah.
Okay, thank you. So to answer Senator Saslaw's questions, the purpose of this bill is really to be an intervention for the maternal mortality crisis in Virginia. Actually, in Virginia, we have greater disparities in our maternal mortality crisis than at the national level. Nationally, black women are dying 2 or 3 times more than their counterparts in pregnancy-associated associated deaths. In Virginia, tragically, mortality rate is 3 to 4 times higher, and so there is a huge disparity. What this bill is doing is to establish 2 hours of unconscious bias, and this is defined here now in the substitute, means bias or prejudice that's present but not consciously held or recognized. And so this would be 2 hours of training as a criterion of eligibility for all healthcare professionals seeking renewed licensure every biennium by the Virginia Board of Medicine. Just as a bit of background, in 2006, when maternal mortality rates were rising across the country, California went through a comprehensive overhaul of its system and established a collaborative with Stanford University School of Medicine to implement a series of clinical interventions. And these changes reduced the total number of deaths, but not the disparity, which held the same exact ratio. Black women were still dying 2 to 3 times more than their counterparts. And in 2016, black women were 6 times more likely to die than their counterparts. And so this has been an issue of concern, not just in Virginia, but across the country. So in order to focus on the issue of concern, we are asking that we have implicit bias training that would address these issues and help our healthcare professionals understand the kind of biases that they may carry but not be conscious. We know that there are biases that manifest themselves in the areas of medicine throughout history that result in very poor outcomes for Black and brown individuals. This bill is supported by a variety of organizations, including ACLU Virginia, Birth and Color, Families Forward Virginia, and a whole list of other organizations. And Mr. Chair, I know we have many people here who would like to speak in support of the legislation.
All right. Are there any questions of the patron?
So I have a question.
Yes, Senator Lewis.
So, Senator Osmus, so the idea is that the cause of the disparity is a bias, an unrecognized bias that's going on?
Yes. To put it bluntly, yes. We've got some historical documentation. There's, even in medical literature, there's research that demonstrates that there's been this misunderstanding about levels of pain and pain threshold even among Black and brown individuals. Physicians have been seen to not prescribe painkillers or pain remedies to the same extent to Black and brown individuals because the threshold of pain among minority communities is perceived by the physicians to be greater than among white people. So those are that's just one example, but we have many cases in which just the figures in front of us, that the level of care that Black women in particular receive either during pregnancy or postpartum is disparate to what the level of care their white counterparts receive, and the level of mortality is greater.
All right. Are there other questions or comments? All right. Then we will take public testimony at this time, up to 3 minutes total for those who are supportive, and then we'll 3 minutes for anyone who's opposed.
Good morning, Mr. Chairman, members of the committee.
Good morning.
I would add to one of the questions to answer that question before I go into my comment. Virginia's maternal mortality review team found in 2019 that the most prevalent factor for pregnancy-associated deaths in Virginia were provider-related factors, and those included a delay or a lack of treatment, diagnosis, follow-up, referral, or consultation. All of those are preventable because they are correlated to unconscious bias in a healthcare setting. I'm Dora Muhammad, Thank you for having us here. I am the Engagement Director and Health Equity Program Manager at the Virginia Interfaith Center for Public Policy. I drafted the bill. I'm spearheading it. In my work, I represent... Okay, I should take this off. I represent 25,000 people of faith and goodwill, as well as over 900 faith communities in Virginia. I'm also representing today the Push Maternal Health Care Coalition, which consists of 20 statewide organizations. In my role, I've heard many stories from more than 100 women, the same story in the public. Before I heard the same story from a close relative who was young, who lost 2 pregnancies last year due to being sent home from the emergency room without any examination, ultrasound, or full consideration of her pain. The stories are horrific, they're traumatic, and most tragic of all, they are preventable. Last spring, I reached out to the Board of Medicine to consider supporting this bill. The executive director brought it before the legislative committee. I gave testimony along with several members of the coalition. The legislative committee voted unanimously to bring it before their full board. In June, I gave testimony again. However, the board was split. They could not reach a consensus to support the bill. They did vote, however, unanimously to offer information around bias trainings to their members via their website or their newsletter. But that's not enough because it's optional. The National Cancer Institute has said that implicit bias is the most insidious but least recognizable mechanism that causes disparities and inequities in healthcare. So we have to do more here in Virginia. I've been told that what I should be focusing on is making training, this bias training, a part of schools, medical schools curriculum. But those are future practitioners. This bill seeks to address those who are practicing now, because women are dying now. Babies are dying now. And we have to do a proven intervention. And so I would say to you, that is what is before you. I do know that there are some, probably who speak today behind me, who take issue with the GA having oversight and legislative authority over the Board of Medicine. For me, that's a tangent for another discussion, for another day, when we have black women dying at the rates that we are here in Virginia. You all have the authority right now. And so I urge you to make it a priority for physicians to abide by their oath to first do no harm, because unconscious bias in healthcare settings is doing the worst harm. And so with that, I urge you to support SB 456. Thank you.
Senator Lewis.
I mean, what you're describing to me sounds like good old-fashioned malpractice.
Well, because we all have bias, so it's not, I think, because it's intentional. And so it is a proven intervention as part of sort of a comprehensive approach. And so I suppose if it was explicit, it could be considered malpractice. But because truly in this realm, and I would say this, endorsed here in Virginia, the Virginia Public Health Association has endorsed this bill. The American College of Midwives has endorsed this bill. The American Cancer Society has endorsed this bill. Because there's an educational intervention that's possible before you go to legal recourses. And so we have seen across the country, there's 13 states that have implemented this educational intervention and have seen the results. And I believe we can do it here in Virginia.
All right. Yes, Senator Newman.
About the base of the bill. Is this about anesthesia? It looks like it's kind of about anesthesia in the bill. Is it broadly with all docs or nurse? Who would be covered, I guess, the question.
For this training, it would be for all healthcare professionals. We know that while the greatest impact, we hope, is going to be on the issue of maternal mortality rate, we know that women and babies interact with the medical profession at a variety of different levels, and so anesthesiologists would be part of it, certainly, if they are in the delivery room, and they too are necessarily a part of the medical team.
Mr. Chairman.
Yes, Senator Newman.
Just trying to get my four corners. Staff, why is it in the why is it in these two sections, right? Are these two sections much broader than what the bill reads?
Mr. Chair, Senator Newman, these two sections are the same section repeated because one is in effect until July 1st and then one is in effect afterwards. The section is about continued competency, and then there is a subsection in here about, I think, continued competency for office-based anesthesia. I'm not really sure why it's together in the code, to be honest.
I can answer that. So I specifically updated for this code because the 2 hours of continued competency was the response that the GA did in 2016 in response to the opioid crisis. And in my view, the maternal health crisis in Virginia demands an equal reaction. And so it is that place in the code that is updated to add this as the additional continued competency to be eligible for a license.
Thank you very much. George, I don't know if I got the answer, but maybe we can work on this. I don't understand why it's in these two sections if the goal is to hit every licensed person out there. Maybe I'm just not understanding how
Office-based anesthesia.
this, both of them say they're anesthesia, so.
So I think anesthesia is in the title of the bill, but it's also about continued competency, and it's not just continued competency for anesthesia. There's subsection F about anesthesia office-based practices, also about continued competency for them. But the rest of the bill, I think, deals with, or the rest of the code section deals with continued competency for other practitioners.
Mr. Chairman, just if we could just look at it as we go through, sir, just why lines 13 and 14 and lines 35 and 36 are so prescriptive, that would be helpful to us understanding who it really applies to. Nothing about the bill, just the way it's drafted.
Question for staff. If the first reading of this section of the code, which is in lines 13 through 34, is effective until July 1, I assume we really don't need any language here because this would not go into effect until July 1.
Mr. Chair, I don't disagree with you. This is just the way that our editing department, we like to lay it out twice in case something changes in this section. You know, they get rid of that during this session. So then we have it in both places. Does that make sense?
Okay.
If those changes are removed during this session, then it would revert back. So we need to have both amended.
Yeah.
That makes sense.
Okay.
It's a technical thing.
All right. Any other questions anyone has? All right. Is there anyone to speak in opposition to the bill?
Good morning, Mr. Chairman, members of the committee. Scott Johnson, General Counsel for the Medical Society. I've not seen the amendments, but to Senator Newman's question, we're more concerned with the process and where this is located. To the health practitioner, Senator Newman is right. The practicing attorney is not going to be looking in an office-based anesthesia section to figure out what continuing ed a licensee may need. Historically, the General Assembly has been reticent to tell any of the health regulatory boards what you have to require as far as continuing education. But if you want to tell them something, I would suggest not putting it in these statutes, but do a Section 1 bill to direct the board to say, if you need to do implicit bias training for 2 hours, do that. And that would be the place as opposed to these code sections, because I think that even though Senator Hashmi is very well intended, this isn't a vehicle to take her to the destination she's trying to get to. So we're more concerned with process as opposed to the outcome. So maybe if we could work with her to help get this in the right vehicle, that would be a way for y'all to consider.
Mr. Chairman?
Yes, Senator Edwards.
As chair of the Code Commission, I can tell you that it wouldn't be appropriate for Section 1 because the code has, everything's in the code that is continuing on and is not, and affects a whole statewide. So in other words, Section 1 bills are appropriate, for example, to direct the secretary or something to buy a bridge, a one-shot deal. It's not something that's continuing. So this would be something continuing.
Mr. Chairman, I'd just say to Senator Edwards, I wouldn't disagree with him. If it is the direction of the committee that you want this to continue, I would suggest we write a new code section to say the Board of Medicine can determine up to 2 hours each year what is going to be a target, because this year it's implicit bias, next year it may be something else, a target issue, and then maybe on that bill put a second enactment clause to say, and the Board of Medicine's first target needs to be implicit bias training that Senator Hashmi wants to achieve. And again,
All right.
I'd be glad to work with her over whatever time you tell me to make that happen.
All right. Senator Hashmi, you want to respond to the suggestion from Mr. Johnson?
I think our goal is to ensure that we have this conversation and that we are providing adequate training for our medical professionals so that they are conscious of implicit bias and its implications and its impacts on health outcomes for minority populations. If it's the will of the committee that we have the conversation, our goal is to achieve this and make sure we move forward. So we are happy to work with Mr. Johnson to do that.
Does anyone want to make a motion relative to?
Chairman, I'd like to speak to the bill if I may.
Okay, go ahead.
Thank you,
Go ahead.
Mr. Chairman. As an OBGYN, I do over 30 hours of continuing medical education annually, which is required by my board certification and already required by the Board of Medicine. In my continuing medical education almost every year, and most targetedly last year, my professional organization had a very great educational program on implicit bias. So, Mr. Chairman, this is something that is regulated by regulatory boards that oversee my professionalism and my education and continuing education. And not only do I not think it's necessary for the state to step in, I think it's setting a bad precedent if we're going to start stepping in. And in addition to what the professional organizations and experts say we should be learning, and they're very acutely in tune to this issue, that we now that the state is going to layer on whatever it is that they think is important at that time. So my motion would be that we pass this by and we can give it consideration. But I would encourage them to look at the training materials that are in every subspecialty already in our required recertification and continuing medical education, because I guarantee you that there is training that is in play that is high quality, that is targeted to specific specialties, so that this issue is addressed very comprehensively by the professional organizations. So that's a motion, Mr. Chairman.
All right. There's a motion to pass it by for the day. Have you worked with Mr. Johnson and potentially others, and maybe consult a little bit with Dr. Donovan, and then we can take a look at this again.
PBI.
Oh, pass by indefinitely.
If I could just respond before committee votes on its final decision. I fully understand Senator Donovan's outline of the fact that there is extensive continuing medical professional training that occurs. I understand the rigors of the profession. My comment would be that if the training in this particular area were fully effective, we would not be seeing the severe disparity of outcomes that we do have. Our data clearly shows that there are disparate outcomes for minority communities around the issue of maternal mortality rate. I think we need to re-examine the training that's offered and address why the data reveals that there is such poor outcomes for women and their babies who are dying in our birthing rooms.
Mr. Chairman, may I respond to that?
Sure.
I think what you see here is a shared passion for maternal child health, which is absolutely shared and what I've spent my whole life doing. However, I think the conversation needs to have what we would call a root cause analysis. And there has been an assumption that the singular cause of poor outcomes in this community is related to an implicit bias. And I would suggest that there's quite a lot of data to say that there are a multitude of other factors. And if we satisfy ourselves that this one conversation is going to resolve the problems we have in maternal child care, we are going to miss the boat. And the root cause analysis would lead us to a multitude of variables that we have to fix in order to fix this problem. And so just to make that point, I think that we have to be very careful about leaping to a conclusion that the singular cause of a problem is this, because it's not. And there are many other things we need to fix.
All right. There actually was legislation last year that created a commission to study these issues. I got appointed to the commission. I volunteered for it because I've worked on these issues in the past. The commission never met, which was rather frustrating given that, there had been a lot of discussion about this issue last year. And I was hoping that would help us get to what are the issues that we need to address, and it's not just a single issue there. But unfortunately, the commission never met, and I did talk to the patron of that, and still hope of getting her to call meetings of the commission, but we never had any. So I'm a little frustrated, coming from that standpoint when we dealt with it last year and had something that would have started the process of providing that information. So, yes.
Does the commission still exist?
Yeah, the commission still exists because it was established in code.
What do you think? I mean, would it be appropriate to have a motion to carry the bill over and have the commission review it? Because I just don't think there's nearly enough data. I'd love to see if I thought that this bill would change mortality in a substantial way,
right,
or that there was true bias out there, that people were doing things to harm certain women, absolutely. But there's I don't know of the evidence that we have of that cause and effect. So if you're okay with it, sir, I'd like to make a substitute motion that the bill go by for the year and that the subject matter be sent to the commission.
Second, and I withdraw my prior.
All right, so the motion is to carry the bill over for the year and to have this issue, as well as other issues, examined by the commission that we set up last year, even though it never met. So is there any further discussion on this issue?
I'd just like to point out so that the board that had exclusively McCullough and Northam appointees on it split. That's right.
What now?
The board that reviewed this, there was exclusively members that had been appointed by Governors McCullough and Northam, split on this. Okay, thank you.
All right, so the motion is to carry the bill over for the year and have the issue be examined by the commission that was set up. If there's no further discussion, you want to call the roll.
Senator Saslaw?
No.
Senator Newman? Senator Edwards?
No.
Senator Lewis?
No.
Senator Dunavant?
Aye.
Senator Suderline?
Yes.
Senator Pillion? Yes. Senator Barker?
I'm going to abstain on this motion.
Okay. Ayes 4, noes 3, abstentions 1.
All right. And see what you can do to work on this and sort of figure out sort of where we need to go long term. So thank you.
Thank you, Mr. Chair, and thank you, members of the committee.
All right, thank you. All right. Senator Chase.
Well, I know.
That's my docket. Yeah. Yeah, good morning.
Good morning, Mr. Chairman and members of the committee. I'll be presenting to you Senate Bill 711 this morning. This bill as it relates to off-label use for prescription drugs. And Senator Newman alluded to this bill that would be coming as a broader version of a bill that I presented to the committee on Thursday of last week. What this bill does is it provides that a licensed healthcare provider with prescriptive authority may prescribe, administer, or dispense a drug that has been approved for a specific use by the U.S. Food and Drug Administration for an off-label use when the healthcare provider determines in his professional judgment that such off-label use is appropriate for the care and treatment of the patient and provides a pharmacist from refusing to dispense a drug for off-label use if a valid prescription is presented. Mr. Chairman, the purpose of this bill is, first of all, I'm bringing it on behalf of many doctors that have reached out to me, as well as patients who have successfully used ivermectin at the direction of a number of doctors who are in this room, to include Dr. Sheila Fury, who is here today, and Dr. Elizabeth Mumfier, and then we had at the presentation, who flew in from New Hampshire, Dr. Paul Merrick, who is let me find his background here, but he is all these are board certified doctors. And I've also had many other doctors to reach out to me privately, and they said, look, we're concerned about being fired. We work at a hospital in Northern Virginia and all across Virginia. We are concerned that although we have been prescribing some of these known off-label drugs, specifically, and I will address hydroxychloroquine and ivermectin to treat COVID. They were doing that successfully, treating patients, and then all of a sudden they were told they couldn't do that anymore. They were being disciplined. They were threatened at hospitals that they would be fired, receive disciplinary action, and it has left many patients dying who don't have options. And so it is our desire, Mr. Chairman, that we make sure that no pharmacist shall refuse to dispense a drug pursuant to a valid prescription for such drug issued in accordance with subsection A, and also that doctors don't have to fear. I mean, we should take the politics out of medicine and allow these doctors to do what they feel is best for the patient. With that, I would tell you, last year we legalized marijuana in Virginia, and then, we've brought forward this COVID vaccine, which has been around less than a year. Yet ivermectin and hydroxychloroquine, these are drugs that have been around since the late 60s and early 70s, even before then. I would also bring to your attention the right to try law that is the law of the land here in the Commonwealth. These patients deserve the right to try these known medications. It's already happening with great success. I'm currently on ivermectin as a prophylactic, and many other patients, which I hope you will give the time and opportunity to our doctors here today to talk to you about the effective treatment that they have had. And just, there are many, I've got a whole list here, and I'm not going to read them to you, a list of 10 surprisingly off-label uses for prescription drugs and their effectiveness. It's a practice that has been used in the Commonwealth for decades. And, many of these doctors are coming to me and say, I never thought we would have to codify this, but apparently we need to, so that we can continue to prescribe some of these known off-label medications. One particular court case.
All right, try to wrap up pretty quickly.
Yes. One last court case I want to bring to your attention is a recent one. Fauquier County Circuit Court's Judge James Fisher did not rule on the efficacy of ivermectin, but said in his opinion that the Davies family could pursue the treatment because of state and federal right-to-try laws that allow patients to try unproven cures when all other options are exhausted among the legal reasoning. And I have a number of doctors and medical professionals that I would ask that they be given a little bit of time to, since they're the experts, to let them speak on this matter, if I could, Mr. Chairman.
All right. Are there any questions of the patron?
I have one that I reluctantly ask. So I received emails from some folks that usually do not share positive sentiment about your legislation, supportive of this, that are and in it they said that they liked it because they didn't think that anything that a doctor prescribed should get in the way, and then they listed things and included ending a pregnancy. And I don't think this is the way that we want to handle the other issue, which I think we all have strong thoughts about. But that was just something that I was unexpected when I was reviewing constituent correspondence to see some of the folks that more often email me in support of some other senators' legislation telling me that they really like this one. And so I just want to ask if that's something that came across in any of the, because I know you've had to spend a lot of time on this.
Absolutely. No, that particular issue has not. We were, in all honesty here, our focus was the tremendous number of deaths that we've seen as it relates to COVID and trying to find other options. And the desire, as presented, was to have a broader bill that would encompass more issues. And, I sent out an email last night to inform my constituents that I would be presenting this bill this morning. I was dumbfounded at the number of people that responded back, doctors, nurses, who've talked about loved ones who are in critical care, some of them on ventilators, where their conditions completely reversed as soon as they got on ivermectin, hydroxychloroquine under a doctor's care. I think this bill is going to save lives, Mr. Chairman, and I believe that we should give those patients the right to try.
All right. Are there any other questions for the patron? All right. We'll try to take testimony first and those in favor, and then we'll do those who are opposed. And we don't have a whole lot of time, so try to go quickly. So I appreciate it. So.
I'm Dr. Sheila Fury. I became involved in the treatment of COVID when my patients were being discharged from the ER in respiratory distress and told to come back when their oxygen saturations were less than 90. I knew that if I did not act, they would die. So over the last year, I've treated over 200 patients with the protocol developed by the doctors at the Frontline Critical Care COVID, the FLCCC. Where my hospital colleagues are afraid of people with COVID, and some of them even wish death on the unvaccinated, I am treating the vaccinated and the unvaccinated because the disease does not discriminate. I am doing home visits on patients who were told that ivermectin and hydroxychloroquine would kill them. I am seeing high-risk patients, and I am giving them prophylactic treatment with ivermectin, hydroxychloroquine, and the vitamin protocol that has been developed by doctors all over the world. This is effective treatment. There is over 70 studies and a prospective study of 160,000 people in Brazil that shows the effectiveness of these interventions. And yet we are prohibited or limited in our ability to use them in Virginia and throughout the United States. I am currently treating a woman who her husband took her out of the hospital because the hospital offered two things: remdesivir, which causes kidney failure, and intubation. When I spoke to the family, her oxygen saturation was 88 to 91%. I implemented the entire protocol. I was contacted last night. 24 hours later, her oxygen saturation was 97%, and she is no longer in respiratory distress. This is something that I am seeing every single day in my practice. It is abominable, and it is malpractice, in my opinion, that doctors in our hospitals are not doing this protocol. The only protocol they offer is one that was given by the CDC, and it doesn't work. They're given remdesivir, which causes kidney failure, and then they have to intubate. This is a protocol that is working. Is it going to save every life? No. We know that there are significant comorbidities in patients, but we could have saved thousands of lives by doing this protocol. Further, we knew at the very beginning of COVID how important vitamin D was, particularly in our minority community, where the ratio of death in the minority community is 2 to 1. We know that because vitamin D levels in the minority community are low, and if we've gotten those vitamin D levels greater than 50, we would have saved thousands of lives, prevented hospitalizations, and not disrupted the entire lives of everyone in our community. This is something that can be done. It's low cost. And this is what we need to do. This is a safe, effective treatment that has been used all over the world, and yet we are wed to pharmaceutical companies and big pharma, and we need to change that. This is low-cost intervention that will save lives, and this is what everyone in this room is here to speak about today. Thank you.
Thank you. All right.
Thank you. I'm Dr. Elizabeth Mumper. I'm a pediatrician with 41 years of experience, board certified, multiple leadership positions. In summer of 2021, local pharmacies, specifically I'm calling out Walgreens and CVS in Lynchburg, refused to fill my prescriptions for ivermectin if I was using them to treat COVID. I provided 97 references to the young pharmacist in Lynchburg who told me he couldn't understand why I would be using an anti-parasitic drug because didn't I know that COVID didn't have an exoskeleton? I was quite aware of that, but ivermectin has a long record of use as an antiviral and an anti-inflammatory. In fact, countries like Tasmania and Tanzania and Mexico and Argentina have much better records than the United States because they use ivermectin widely in their population. In fact, a poor state in India called Uttar Pradesh has over 200 million inhabitants, and they essentially brought the COVID pandemic to an end in their country because they gave their citizens ivermectin, zinc, and vitamin D. In this country, I can't write that prescription except at 2 pharmacies in Lynchburg where the cost is now escalated from $20 per course to between $88 and $300 per course for ivermectin. There's a compounding pharmacy in New York that will do it for $4 a day, and I might have to send my prescriptions there, which is not good for the Commonwealth. Dr. Paul Merrick is among the top 3 intensivists in the world, and Virginia was very lucky to have him on one of its medical school faculties. He's published over 500 critical care articles in the medical literature, and when he was on service at the ICU in Norfolk, he had half the mortality of his colleagues who were using the protocols that were sent down by federal guidelines. These include remdesivir, which is a dangerous and toxic drug, and when it was used in an Ebola trial, they actually had to cut off the remdesivir arm of the trial because so many patients were dying, and yet that's what we are offering the citizens of Virginia in our hospitals. Dr. Merrick was prevented from going above 6 milligrams per day of dexamethasone in adult patients fighting for their lives, and that is the dose I use in a 6-month-old who has croup. He texted me in despair when this was happening, saying that they were, quote, they are murdering my patients and forcing me to stand by. So 7 of his patients in the ICU all died, including a 32-year-old Virginia woman, and he knew he could have helped at least some of them. This is not an issue of vaccinated versus unvaccinated. This is an issue of access to treatment or not. Let doctors be doctors, let nurses be nurses, and let us do what we have trained so hard to do, which is to save lives and heal people. Thank you so much.
Thank you.
I just have a question for the doctor, if I may, real quickly.
Yeah.
Obviously, I support letting doctors prescribe off-label, whatever, but I'm not sure how this bill accomplishes what you're seeking. Because we have a political motivation for the pharmacies in many cases to not be filling the bills, not be filling the prescriptions that are off-label. They fill off-label stuff for us all the time. And so I don't know, in all honesty, I don't know that this bill accomplishes what you want because This bill just says the board can't have a hearing and hold you accountable for your license for prescribing. I'd be interested to hear from the board. I have been on the Board of Medicine. I can't ever think of a time that the board ever asked anybody that ever had a hearing for somebody and threatened their license, which is what they have the power to do, based on off-label prescribing.
I thought one of the parts of the bill was no pharmacist shall refuse to dispense a drug. And that's my big issue, is that these young pharmacists straight out of pharmacy school are refusing to consider the broad body of literature about the value of ivermectin.
Just honestly, as somebody who advocates for medicine to stay with the medical people, we are going to prescriptively tell a pharmacist what they have to do within their own code of conscience and their practice parameters. We wouldn't want somebody telling I agree with the problem. I totally agree. I'm just saying this is now dabbling in pharmacists, you must do what we say despite what you think about your license or your ethics. We would never want somebody to tell us that.
But the pharmacist told me that the reason that he said that was because the FDA had said that ivermectin is not approved or recommended in this situation.
But every clinician has to interpret their responsibility, you know, and their practice based on the guidelines that they hear. But I'm just saying, I get the plan, I get the process, I get the idea, and I agree, as I have supported other ways to protect physicians' ability to do the right thing for their patient in the past. I just have to say I am worried. I'm curious to hear from the board, but this is getting into an arena that makes me very uncomfortable because, in a way, we're telling other people what they have to do.
So maybe let legislatures be legislators, and you guys figure out how to accomplish what it is that we are trying to do in order to save lives, because Virginia
Bingo.
citizens are dying.
Agreed.
Yeah, why don't we put it, we got a couple other meetings we got coming up, starting at 10 o'clock. So why don't we take basically 1 to 2 minutes in your presentations.
I'll be quick. So in reference to what you're saying before we get on with this, my name is Kim Day. I am from Chesapeake, Virginia. I am a nurse of 25 plus years. And in regards to that, I can vouch. Being a nurse for 25 years, doctors have always prescribed medications off-label for multiple diseases. That is nothing new under the sun, and it should not be for this. Also, I will say, I have spoken with several pharmacists, young and old, or mature, should we say, and they too have said they have been instructed to report doctors to the medical board to lose their license for trying to prescribe ivermectin or hydroxychloroquine. So, for what it's worth, just letting you know that. I, as a nurse with multiple comorbidities and autoimmune diseases, have had COVID in December. I was treated with ivermectin and the Math Plus protocol, responded beautifully, did not require hospitalization, did not require a ventilator. And furthermore, I have a large family. My parents in 70s, 70s plus, they too got COVID, used the Math Plus protocol plus ivermectin, diabetic, high blood pressure, atrial fib, you name it. We got these diseases, asthma. Everyone in my family did ivermectin, Math Plus protocol, responded beautifully. No hospitalizations, no deaths, no ventilators. So take that for what it's worth. I'm not sure where the problem is in the United States right now, but it is a big problem that needs to be solved, and it could start right here in Virginia. Thank you.
All right, thank you.
Hello, Senators. My name is Tricia Stahl, and I am from Matthews, Virginia. You probably remember when I ran against Marty Williams and defeated him, Senate Transportation Chairman, in 2007. And I am here to answer your question, Senator. The problem with ivermectin is you cannot have an emergency use authorization for any medication if there is an existing one that will take care of the problem. Ivermectin takes care of the problem. You are well aware, I'm sure, you are well aware that Africa has the lowest incidence of COVID in the world. And do you know why that is? Because they take their Sunday pill every Sunday. And you know what it is? Ivermectin. This drug won a Nobel Peace Prize, which is very unusual in the medication arena, in 2015 because it accomplished such great success with a range of dermatological issues, parasitic issues, and certainly with this virus that had already been from China many years ago. All of this was being planned. And I say to you that we are witnessing what $6.1 billion in annual taxpayer money will do to accomplish coercive policies involving every established entity in the medical arena. And if you have not seen this book, I highly encourage you. Robert Kennedy, as you know, is a Democrat. He has written an incredible book here with footnote after footnote after footnote.
Crazy.
That's your opinion. In my humble opinion, this man has done a great work by sharing with us the entities that are involved, and it's all the entities, whether it's the CDC, the WHO, the NIH, and whose wife works for the NIH and determines which drugs are going to be suitable for authorization for an emergency use? None other than Dr. Anthony Fauci's wife. He controls $6.1 billion in annual taxpayer funding for scientific research, allowing him to dictate the subject, content, and outcome of scientific health research across the globe.
Mr. Chairman? No, Mr. Chairman?
Yes, yes.
I'd like to ask that she speak to Senator Chase's bill and why she likes Senator Chase's bill and why we should recommend report, because I don't see how we're going to make it to Senate rules or finish the rest of the docket.
Thank you, sir. I will be glad to. I have had 3 acquaintances and friends who have died from COVID, and they were sent to Sentara General Hospital, and they begged for ivermectin. Their families begged for ivermectin. They were refused that. They wanted to put them on remdesivir. Remdesivir is a very high reimbursement to the facilities, to the hospitals, versus ivermectin. It's about 75 cents a pill. So if doctors cannot prescribe medications that they know in their professional opinion will help a patient, where do we draw the line? Where do we draw the line? So I am pleading with you to please allow doctors.
You've exceeded your time, so.
Oh, I'm sorry. I didn't know I was exceeding my time. But I just want to tell you the PCR tests are not reliable, and that's another consideration that we need to take in. And we just need to remember that all the Democrats who flew from Texas up to D.C. on that plane when they left the assembly down there, every one of them got COVID. Guess what drug they were treated with? Mr. Sudol, do you have any idea?
Well, usually we don't take questions like that, but I'm not that close with the Texas Democrats. I'm a Virginia Republican.
All right.
You might want to know your audience.
I know my audience, but my point is that they were treated with ivermectin.
Okay.
Ivermectin saves lives. Doctors should prescribe it. Thank you.
So that's what saved us, the Democrats.
Yeah.
My name is Brian Lansicki. I'm 45. I'm from Virginia Beach, and I got COVID pretty bad right before Thanksgiving. And my doctor would not prescribe ivermectin or hydroxychloroquine, and they sent me home with an antibiotic, which turned out to be the wrong one also. And I found Dr. Fiore through an acquaintance of an acquaintance and talked with her over the phone. And I was about 6 or 7 days into COVID without anything other than the antibiotic. I got the ivermectin, and the next day just immediately started to improve. And I don't understand why doctors are not allowed to prescribe this, why my doctor tells me that they can't prescribe it because nobody will fill it, and they're going to get in trouble if they do prescribe it for me. I finally get it, and it saves, I turn around in a day. So that's all I have to say. Thank you.
Hi, I'm Trevor Chapman. I'm a physician in Roanoke, Virginia, and I came here to speak on the concern of the off-label prescription use. Senator Donovan, I understand your concern, and that's my concern as well. The real issue here is the pharmacies are not filling the prescriptions. The doctor writes it, the patient takes it there, and the pharmacies refuse to fill it. In Roanoke, when I had COVID in October, me and my wife, we got our prescription from our doctor. Well, there was only 2 pharmacies in Roanoke that would fill it. We did finally get it filled. We did fine. The other concern with this is if we start limiting off-label use, as you know, my specialty, that's half of my practice. That's every day. There's thousands and thousands of prescriptions that are written for off-label use. We want to curtail the use of narcotics in pain management. Well, what do you think we do? We go to off-label use of other things, Neurontin, Lyrica, things like that, so that we have other options besides narcotics. So this not having some protection over the off-label use of medications is going to be critical for continuing to provide care for patients. I appreciate your concern. Maybe we need to take another approach, but find out how is it that a pharmacist can take a prescription written by a doctor and say, hell no, we're not going to fill it. We don't care what you like.
Mr. Chairman,
Yes.
just to comment and keep the conversation going, we're going to get some information from the board about whether or not there are being doctors that are tracked. I think if we looked at this, we'd see these are corporate decisions. We know almost all the pharmacies now are big conglomerates, and this is not an individual pharmacist even within their power to make the decision because they have corporate decisions that we don't agree with. But off-label is protected by the federal government. We have the right to prescribe whatever we think. As long as we consent that patient, we have the right to prescribe off-label.
All right. Time is up. We need to move along, so for the last people, come up and tell us your name and tell us your position, and then let somebody else come up.
Well,
yeah.
Thank you all for taking the time to hear from all of us today. My name is Philip Andrew Hamilton. I actually ran for the Virginia House of Delegates in Charlottesville last year. While I did not win, but I'm here as a citizen fighting for medical freedom and for medical treatment. And medical freedom involves, we're not talking just about the mask mandates and vaccines. This is a very tailored issue.
Yeah.
And
can you try to move along quickly because we don't have time. So
I
just
support
speak
the bill
directly to the bill and let us know your position.
Sure. So I support this bill 100%. It's going to save lives. And I'm friends with Dr. Sheila Fury. I've heard many of her stories about patients who've their lives have been saved by the protocol that she's enacted. And these are things that you should take seriously because we shouldn't have Virginians traveling to other states that get the treatment that they deserve. This legislation will prevent that from happening.
All right.
So again, support this bill.
Thank you. Thank you. All right, next. Yeah.
My name is Bonnie Stewart, and my daughter went to college in August at Liberty University. My husband and I went there 2 weeks after she started school. She got COVID. We went to help her there. We both got COVID. My husband's went to Lynchburg General. We called the same pharmacy in Lynchburg to get our ivermectin before he was admitted to the hospital. He was admitted to the hospital on September 12th, and he was intubated on September 25th, and he was airlifted from Lynchburg General, where he would not have made it, to UVA Medical Center on October 1st. Governor Bob McDonnell, previous governor, he made the call to UVA and got a bed for my husband. And my husband right now is facing a lung transplant. If he would have got ivermectin, it would have taken the inflammation out of his lungs. And right now he's on the ventilator at 5 months. He's on the ventilator at UVA. And we were just told I am not able to see him because of the mandates right now with not being allowed to go into the hospital. And I was just told on Saturday that my husband needs a lung transplant. He's 57 years old. He's a Navy veteran, and he served in the Gulf War. And he was a picture of health. Had he gotten ivermectin when we ordered it and had it sent to the pharmacy there, we're from Virginia Beach, and I've been going back and forth. And so this is so personal to me right now that please please consider this bill.
Thank you. Thank you.
Madam Chair, I have a question.
Yes.
My question is, your husband, was he vaccinated before? Was he
No,
vaccinated?
he wasn't.
Okay. Thank you.
Good afternoon. My name is Kimberly Eastman. I was hospital bound by day 10 because my oxygen level had dropped below 90 and my primary care physician offered no treatment. I can say unequivocally that the Math Plus protocol, including ivermectin, kept me out of the hospital and I believe saved my life because on day 11 I came under the care of an FLCCC doctor. I do want to address the cost of the ivermectin and the ability to get it. There was one compounding pharmacy in Richmond that was doing it, and they stopped doing it in the middle of my treatment. And they told me because the Department of Health had come down on them. So for whatever that means. You and your loved
try to
ones
wrap this up.
and all of our
to move
fellow
along.
Virginians should have access to the same type of life-saving care. Thank you.
All right. Yeah. Yeah. Try to make it quick.
Good morning.
so,
Thank
yeah.
you. I know it's kind of hard to.
Yeah.
My name is Pamela Burnham. I was a critical care nurse in the hospital system for many years. I've worked with infectious disease patients all over the country. When COVID hit, I knew the system was broken when people told to go home until they couldn't breathe. I alerted my community and my friends. I have been advocating primarily for COVID patients and families for close to 2 years now. I encouraged everyone I knew to stock up on meds. I've helped probably close to 1,000 people. They're terrified of the hospital system.
Try to address the issues in the bill.
Okay. Well, our entire family was hit by the Delta variant, including my 87-year-old mother-in-law. Our family was hit very hard. I've helped both vaccinated and unvaccinated people recover from COVID. Early off-patient label treatment with many FDA-approved medications like ivermectin and hydroxychloroquine, along with vitamins and antibiotics, have been life-saving, as everybody has stated here today. Overwhelming evidence is available by frontline physicians. I support a patient's right to try any legal medication that their physician thinks is appropriate based on their professional clinical judgment. Please do not prohibit off-use label.
All right, thank you.
Okay.
Hello, thank you.
All right. Try to go
Right.
quickly.
I'm Barbara Zedler. I'm a recently retired physician after more than 30 years of practice in internal medicine and scientific research, and I speak in strong support of this bill and to provide some clarity for people who are not necessarily as familiar with what it means, these terms. FDA approves medications as safe and effective for at least one disease or condition or use. Okay, that's in the label.
Right.
They do not control how physicians, in their professional judgment, prescribe those medications to treat patients. Off-label use, meaning for other conditions, other doses, other frequencies, other patient populations such as children or people with renal impairment,
Right.
that is legal and common for FDA-approved medications. For almost everyone, I dare you to find one that isn't used off-label for another condition. And that comes from use, real-world evidence developed after decades of use in patients, that they're useful for other conditions.
Okay, try
In
to
fact,
move
an average
along.
of 20% of commonly used medications are prescribed off-label every day. And in some populations like children, pregnant women, cancer patients, it's a far higher proportion. If you prohibit that, you will lose the ability to treat those. Let doctors be doctors and do not allow the Board of Health Professionals, the Board of Pharmacy, or corporate pharmacy and hospital systems to persecute them for complying with legal and long-standing best medical practices. Thank you.
All right, just quickly, we're over time here, so just
Real quick, it's really quick. Okay, so we all have liberty, and that includes our right to try life-saving medicine. The pharmacists that are infringing upon our liberty are actually in violation of real law. Thank you.
Thank you.
Good morning. My name is Chris Nestor. I practiced pharmacy for about 34 years. I retired about 10 years ago. I worked at VCU Medical Center. I share with Dr. Donovan some of your hesitancy about removing the ability for a pharmacist to deny filling a prescription because misprescribing can and does happen, and he's a line of defense, just like a nurse is. But to your point, Senator,
yes,
when you asked about the whether the woman had been vaccinated or not, it seems to me that when a experimental medicine like the so-called vaccine is recommended for 100% of the population, that's unprecedented. I've never seen that before. It seems to me what should happen is recommendations can be made, but a patient has a math problem. They need to decide whether they want to risk the problems that can result from taking a new vaccine that usually takes at least 5 years to evaluate, or seek available treatment such as what's been discussed here. I rise in defense of heightening awareness of this ridiculous thing that I've never seen.
All right,
Medicine will never be the
your
same.
time is up, so thank you.
This is very hard on me
Yeah.
to stand in front of all of y'all. I get real nervous.
Okay.
But I feel like I need to say something about my mother, especially to you, sir. She's 82 years old. She caught COVID, almost died. I had a wonderful doctor, Dr. Fleury, tell me what I needed to do to help her. And it worked. It really did work, including with the Math Plus protocol in ivermectin. My 82-year-old mother would not be here. And that's the truth. So please.
Thank you.
Let this bill pass, please. It does work.
All right. Is there anyone who wishes to speak in opposition to the bill?
I move that it be passed by indefinitely.
All right, there's a motion to pass it by indefinitely.
Speak to the motion.
There's second.
Can we speak to the motion real quick?
I'll second the motion. Yes.
Just speaking to the motion, I'm going to vote. Pass by indefinitely means to defeat the bill, so I'm going to vote against that motion. But speaking to it, I have some serious concerns with how this legislation is formatted. I've spent more time trying to review our pharmacy conscious provisions, and I have very serious concerns that as it's currently before us, and so I'm not going to vote to kill it. I think the conversation should continue, but I think the way that this is currently composed could require some of the pharmacists that I represent that would not be willing to prescribe abortifacients to do so. And that is something that is very problematic, and I will not vote on the floor of the Senate for such a bill. But I'm not going to vote to defeat it because I want the conversation to continue. But I know Senator Chase does not want to do that to pharmacists in Virginia either. But this is a big problem. Yeah. This is a big problem with how it's currently constructed.
All right. Let me,
Mr. Chairman,
point out that the vote that is taken today is not going to be the final action on this. This will go to the full committee regardless of what happens or does not happen today in terms of a motion, and so we'll be dealing with this next Thursday. So,
and Mr. Chairman, there's a willingness of myself to work with members of the committee to satisfy. I have the same concerns that you do, which is why I had the original bill, so it was more narrow focused to avoid that type of situation. So I'm in agreement.
We have a motion And a second.
Before we go, and I know we're in a hurry, but there's a couple of things that matter here. One is have there been physicians that have been disciplined because of their decision? If so, I'd like to know about that.
And the Board of
Yes.
Medicine is here.
Yes, they've
So
been
there's the Board of
fired.
Medicine. Have you disciplined physicians for doing off-label use of drugs? Has that been your practice?
Mr. Chairman and
Yes.
Senator, David Brown, Department of Health Professions, no.
Have you ever disciplined a physician or others because of off-label use of a drug?
No, we have not taken action against a physician for off-label
Are you
prescribing.
parsing the words "taken action"? Has there been anything that you've done?
I'm not parsing words. There have not been cases that have involved off-label prescribing. There certainly are cases of inappropriate prescribing, excessive prescribing of opioids and things like
But
that.
nothing on these drugs. Is that correct, sir?
That's correct,
I'm sorry, Mr. Chairman. David, thank you for your answers. They've got to be very direct, and I apologize for that. Have you or anyone in the Department of Health gone after pharmacists for prescribing off-label drugs as mentioned in this bill?
No, sir. And I would like to just clarify that it's my understanding that pharmacists have an obligation to not fill prescriptions that they believe to not be legitimate. And so the board has not taken any action, but there is language, which I think is what results in some pharmacists filling something and some pharmacists not filling something in addition to the corporate requirements.
My question is more narrowed, right?
Yes.
So the narrow question is, has the board or others in the Department of Health threatened pharmacists with action based on these drugs?
No, sir.
So, Mr. Chairman, and I know I took a couple minutes of the time, but a couple of things. One, I think David's concern here is a magnificent concern. We cannot overlook the mandating of anyone to prescribe something that they morally disagree with, so that it just has to fix. The other thing is that I think we've got to be very clear. Thank you, David. I appreciate it. Very, very clear, because to me, and I'm just one little guy of 40, if the Department of Health is out there doing this, or we find out the Department of Health is out there doing this, I think there ought to be, because we're very clear that off-label usage is okay. And if it's not okay, we need to change some people in the Department of Health. That's just the way I would go about that. So to me, I didn't vote, or I abstained on your other bill because it was not a broader bill, and I like this one for the broadness. The problem is the David concern. So I'm not going to vote to PBI it, but I'm with David. If this problem related to RU 486 or otherwise is not fixed, I can't support it either. So I urge you guys to kind of work your way through that. And I'd like to make sure that we understand if somebody out there says that they've been disciplined by the Board of Health, or if the health department has come down on pharmacy, I think this is a call to bring that information in so we can actually find it. Thank you, Mr. Chairman.
All right. Thank you. Yes.
I'm so sorry. I'm sorry to the committee that I feel it's very important that I speak on this. And I will say, I hear your passion. I get it. I get that doctors and patients should be able to look at any alternative that's out there, weigh and balance the positives and negatives, and make a decision about what that patient actually decides. We are informers, the patients are decision makers, and that has been obstructed in this situation. This bill doesn't accomplish what you want. And that's the problem. And that I will not be able to support this bill because I have to have a principle about the state not getting involved in that conversation between a provider and a patient. And unfortunately, despite the best intent, this bill does that. And so I just wanted to say that I have already texted the acting commissioner of the Department of Health to find out if any pharmacy was in any way discouraged for dispensing this medication, and I'll get answers and I'll make sure that I put them out there. And we'll follow up, but physicians have the right to prescribe off-label. Can't answer questions. Prescriptions we can talk after. Prescriptions have the right to prescribe off-label. Patients have the right to try medications that they think might help, even if they're off-label. And I understand that's a problem, and I'm sorry about that, but this bill doesn't fix it.
All right.
Chairman, could I just finish with one last comment?
Not right now. No, I'm sorry. We're well over time here. We've devoted a lot of time to this. So could you, we have a motion and a second to recommend passing the bill by indefinitely, and regardless of what the outcome of this vote is, this will go to the full committee next Thursday. So, call the roll.
Senator Saslaw,
To PBI, aye.
Senator Newman, Senator Edwards,
Aye.
Senator Lewis,
Aye, by proxy.
Senator Donovan,
Aye.
Senator Suderline,
No.
Senator Pillion,
No.
Senator Barker.
Aye.
Ayes 5, noes 3.
And we will take it up again next Thursday. So, all right, we are running late, so we're going to, anyone want to make a motion to adjourn? So,
All right, so moved.